Okay. All right. Well, hello, everybody. Welcome to this presentation about understanding opioid addiction and some pathways to recovery. This is brought to you by a grant from Ohio MOS, and the Cures Grant, and we are recording this today on the campus of Case Western Reserve University. We are at the Center for Innovative Practices at the Begun Center. We're recording this on Tuesday, April 17th. It is tax day, so hopefully when you listen to this, you got everything filed on time like you should. And hopefully when you're listening to this, the snow, which continues to fall in the middle of April, has finally melted, and maybe you can get out and do some lawn work. So what we're going to do is go through a series of slides talking about the statistics, and I think a lot of us have at least a passing familiarity with, or at least a sense of the alarming rise in statistics associated with the use of opioids, and then certainly all of the tragedy and difficulties surrounding the use of opioids, most notably with the deaths associated with overdose. So we're going to go through some of those numbers, really I think giving us a grounding in terms of where we are, the way things continue to rise. Then we're going to talk about some of the specific populations, and then we're going to talk about some of the specific opioids themselves and some of the terminology around it. And then we will wrap up talking about some of the treatment matches that we can consider when thinking about working with clients and patients who are, so strongly affected by this substance use disorder specifically. Everything that we talk about today is going to be kind of a broad overview. We're just going to take about 50 minutes in our discussion today, so that we're not going to, drill down into any really, into the weeds kind of specifics. But hopefully, this will give you the sense and some ideas on where to look for things, and some familiarity with it that way. So, when we originally planned to record this, it was 2 weeks ago, and we had upcoming the Week of Appreciation for Ohio professionals who are on the front line of the opiate epidemic, which was designated by the governor and in association with the county mental health boards and the attorney general. So that was coming up, but unfortunately, we were hit by the flu or something. First, I got it, and then the guy who makes all of this possible, Matt, got it, and so both of us suffered a lot of symptoms that look a lot like what we're going to talk about when we talk about opiate withdrawal. So that's it occurred to me as I was at home suffering with the chills and all the other symptoms that there was some overlap with that we can highlight, but not in any great detail as we talk about opiate withdrawal. So now it's behind us, but Ohio being one of the forefront of places that has really suffered this epidemic, there's a lot of recognition at the federal and at the state level, and certainly at the county level, of the frontline work that many of you are doing. Sorry about the pause here. We're waiting to get the slide to move on to the next slide. We're having a little bit of trouble here, a little bit of technical difficulties. Okay. All right. So we're back. I think we have our technical difficulty solved. That remains to be seen, but that's okay. We'll get through it. So talking about opioids, and if you're familiar with the DSM-5, the designation they use, opioids, opioid use disorder. If that's not something you're familiar with, certainly it's something that you hear. I think opiates with the T is a little bit more common. Narcotics is in there in terms of terminology too. Painkillers, prescription painkillers, heroin. There's a lot of different terms used. But just to differentiate the first two on the list there, opiates with the T and opioids with the D. Opiates with the T traditionally have referred to the products, the substances, the drugs that would come directly from the opium or the opium poppy itself. So that would be opium, morphine, thebaine, and a few of the substances that come directly from the opiate poppy itself, and sometimes then some of the derivatives that would come from those. Opioids that are used traditionally have been used to refer to the synthetic products and the semi-synthetic products, and we're going to talk about those here in a few minutes. But these days, really, they're used interchangeably. I don't think that people pay too much attention to is this a drug that came directly chemically altered a little bit, or was this created in a lab all by itself? Whenever we use the term opiate or opioid, talking about the same thing. And traditionally, going back a long time ago, narcotics also referred to substances in this category. But the term narcotic was kind of taken over, and I think more in an everyday usage sense and maybe in a legal sense. It seems like narcotic squads a lot of times were making marijuana busts. In the 60s, it was LSD and PCP and things like that. So they were the drug squads. But narcotics traditionally referred to things in the opiate category, but these days it kind of has a broader meaning. So as we talk about it today, I will use opiates and opioid pretty interchangeably. So a couple of years ago, maybe about 2.5 years ago here, so January 1st, 2016, the CDC made the first official reference to what's going on with opiates as an epidemic. They published, the United States is experiencing an epidemic of drug overdose. And the rate of deaths from drug overdose has increased 137%, including a 200% increase in the rate of overdose deaths involving opioids. So that was about 2.5 years ago. And, what led them 2.5 years ago to say that? The numbers involved with that. So when we take a look at the numbers that led the CDC 2.5 years ago to say that we were at epidemic levels at that point, they were taking numbers from 2014. At that point in 2014, there were about 48,000 overdose deaths in the United States. And that's a grand total of all overdose deaths at that time. So not just opiates. And pulling from that 48,000, 19,000 were from prescription pain relievers, opiates, and 10,500 were from heroin. So what is that, 30, or we're at the School of Social Work, not the math school, 29,500 deaths from a combination of the prescription pain relievers and from heroin of that 48,000. At that time, looking at the period that they were measuring, 99 to 14, opiate deaths, overdose deaths had quadrupled, and that was matched, and it was absolutely no coincidence, and I think a lot of you are familiar with this at this point. Prescription for opioids had quadrupled in that same time, and it's interesting in an unfortunate way that the prescriptions had quadrupled and the deaths had quadrupled, just going hand in hand. The most common drugs involved with prescription overdose death at that time, methadone, number one, oxycodone, and that would be the generic for the medication that's in Oxycontin, also in Percocet, and hydrocodone. That's what's in Vicodin. So those are the three most common opiates that were involved in prescription overdose death at that time. As we move forward, our most recent numbers from 2016, so this is 2 years later than those numbers, moving from what they called an epidemic at that point now, look how much this has jumped up. 63,632 overdose deaths in 2016. You know, you compare that to the 42,000 from just 2 years ago. Opioids, prescription and illicit, the combination of the two, were involved with 42,249 of the deaths in the United States from overdose in 2016, which is larger than the number of all overdose deaths just 2 years ago. Heroin was involved with over 15,000 of those. Methadone was involved in over 3,000 of those. And synthetics, other than methadone, and we're going to talk about that differentiation. Methadone is synthetic too, but they measure it separately just because of the treatment implications of methadone. But synthetics other than methadone, and here we're thinking of primarily fentanyl, were involved in over 19,000 of those overdose deaths. So when we take a look now at 99 to 2016, overdose deaths have quintupled. Written prescriptions for opioids, though, have started to decrease. So as the prescriptions are going down, and we're paying a lot more attention to the connection between prescriptions and making these types of drugs just so widely available and having them out there in the communities and sitting around in medicine cabinets, that's finally starting to trend downwards. But unfortunately, the connection to people who have gotten hooked, that have become addicted to the narcotics, they're still there and they're still using, and the consequences from that are continuing to increase. So in 2016, these numbers are the same, or these figures are the same from 2014. The most commonly involved ones: methadone, oxycodone, and hydrocodone. The CDC, the Centers for Disease Control, do age-adjusted numbers so that they can compare states to states. So they compare a number of deaths per 100,000, so that we can compare small states to large states. This slide, the total number of deaths listed in each state from overdose death. And this is a combination of all overdose, not just opiates, but opiates really drive that more than anything else. So here in Ohio, you know, we're number 4 on that list. We're number 7 in overall population. And when we take a look at those first 2 states, Florida and California, that are above us, their populations are significantly larger than Ohio, especially California. Pennsylvania is slightly larger than Ohio, not much, but Ohio and Pennsylvania are very similar. And so there we have our 2 Rust Belt states, you know, with significant pieces of Appalachia in both Pennsylvania and Ohio, you know, where we have really been hit hard by this epidemic. Some, you know, connections to the pill mills that were in both states, the industry that was there and has disappeared, and now, you know, other methods of making money, unfortunately, have popped up, and you know, a lot of the linkages. So Pennsylvania and Ohio, very, very high up on that list. And both Pennsylvania and Ohio, more overall deaths, and significantly more so than New York, which is also a much larger state. So Ohio, in terms of overall numbers, 4th in the nation in terms of losing folks to this epidemic. When we take a look at the age-adjusted rate that the CDC does so that we can compare each state against every other state on an equal basis, you know, West Virginia is just so far ahead in a negative way. But, you know, when we talk about those factors, like we consider for Pennsylvania and Ohio, West Virginia But here we are in Ohio, number 2, just barely above New Hampshire. So, and Pennsylvania, number 5 on that list. So in terms of the age-adjusted rate, Ohio is very, very sadly well represented. When we take a look at the age groups, this isn't just for Ohio, this is nationally, but when we take a look at the age ranges, you can see where it really, really spikes. We can take a look at the total number of deaths and then the age adjusted, so the percentage that we're talking about of people that we lose in those age ranges. 15 to 24, comparatively it's smaller, but it's still a frightening number. Over 5,000 folks in that age range have been lost to the epidemic. When we take a look at that, and as we talk about here in a couple of minutes, we're going to talk about the declining rates of use by younger folks, that is up to 18 years old. So that age range, that 15 to 24-year-old age range with the over 5,000 deaths, that's mostly in the young adult range. That's not so much in the teenage range. There is something that we haven't identified yet, whether it's exposure through prescription or exposure through older adults who are using whatever it is. When we take a look at moving from the transition age into full adulthood, that 25 to 34-year-old range, it skyrockets. Look at that difference. It's triple. 5,000 deaths moving up to over 15,000 deaths in the 25 to 34-year-old range. And it doesn't really get any safer. 35 to 44, 45 to 54. The numbers of overall cause of death start to go down as we go up with 35 to 44 and 45 to 54 ranges. But that's because other things also start to become fatal in those age ranges, especially in the 45 to 54-year-old range, when a lot of other factors start to catch up with that age range. But that's still a lot of folks lost every year. And even in the 55 to 64-year-old range, over 10,000, almost 11,000 folks at that point. And the 65 years and older, the numbers start to dwindle. So, we can see where the epidemic is really, really hitting. And it's, I think about all the risky drug use being done by the younger folks, 18 to 25-year-old kind of thing. But we can see by this with opiates, it really captures and keeps a hold of people into adulthood, moving into full adulthood, and even later adulthood. So some numbers specific to Ohio. This is from 2016. We lost 4,329 people to overdose death in 2016. This is a 30% increase just from the previous year. Almost 2,300 deaths involving synthetic opiates, and that's primarily fentanyl, and it doesn't include methadone. Almost 1,500 involving heroin. 867 deaths involving prescription opiates. And so if there is any bright spot at all in all of these frightening, alarming, horrible numbers, but the deaths involving prescription opioids declined for the 5th straight year, and this is one small bright spot. This decline was matched by a 4-year decline in the number of opiates prescribed in Ohio. And Ohio has really led the nation in doing an excellent job in remaining attentive to this, really cracking down on this, especially in terms of the pill mills. We're not going to talk about those too much today, but you can find a lot at some different websites on the pill mills. And in terms of the prescription drug monitoring, Ohio leads the nation in their attention to the prescription drug monitoring. And we use the Ohio Automated Prescription Reporting System, or ORS, which does of making sure that there's not a lot of those doctor shopping overlaps. So this is numbers of people lost to overdose from 2011 to 2016, county by county. And the darker the blue, the more folks that were lost in those regions. And this is age adjusted. So smaller counties are equally represented with the larger counties here. And you can really see where the concentrations are really in both corners of the state. And when we think about some of the rural counties and some of the Appalachian regions, those are both captured there and in the two corners of the state. Has the very unfortunate distinction of leading the state and at least for a point, leading the entire nation in terms of numbers and age-adjusted numbers of opiate-related overdose deaths. In 2017, almost 559 folks were lost to opiate-related overdose deaths. At the beginning of 2017, in the first 4 or 5 months, they were trending towards. They were thinking that they were going to lose over 800 folks, but they had a lot of coordinated efforts, paying attention to and really trying to prevent that. And it did swing things the other direction, but still such a high number, a 60% increase over 2016. So this slide can be found on, oh boy, I can't remember if I found it on Ohio Mass or if it was on the Ohio Department of Health. But if you Google it, if you need this, or if you can capture it off of this slide really has some good talking points in it as you're using this information to help educate people in your agency, people that you work with clinically, and then also people in the community. So I think that we have all heard about fentanyl and the increasing availability of fentanyl. There has been a lot of work in Ohio, and our senators have really done a lot of work in working with our federal government and then also the government in China, trying to decrease the availability of fentanyl produced primarily, we think of in China, that you can order online. And we're going to actually, coming up here, there's a slide that points out just how frightening and easy that can be to access. But in early 2018, the Ohio Department of Health issued an advisory to first responders to administer naloxone, that is Narcan, the life-saving drug for opiate overdose, for all drug overdoses, even when non-opiate drugs are suspected, because with the really high availability of fentanyl and just the overwhelming power of fentanyl, it's increasingly being mixed in with all other street drugs, not just opiates like heroin, but in Ohio they've measured incidences where people have overdosed and they have seized drugs cut with fentanyl that include heroin, powder cocaine, crack cocaine, certainly other prescription opiates, sedative hypnotics, and that would be, we would think primarily with that would be benzodiazepines. Even marijuana, methamphetamine certainly has been cut with it, and Molly, MDMA, or ecstasy. All of these drugs have been found to be cut with fentanyl. So the advice is any drug overdose should be treated with naloxone or Narcan, just to cover the basis. Because if you administer it to somebody who doesn't need it, it's not going to hurt them. So better safe than sorry, kind of thinking. So hopefully we have some hope. Monitoring the Future is a yearly NIDA-funded survey conducted with thousands of 8th, 10th, and 12th graders from around the country. It's a really, really well done survey on not just drug use by teenagers, but also attitudes about drugs, perceptions about drugs, perceived availability of drugs, So if you're not familiar with it and you work with youth, uh, we're going from what, eighth grade is 13, 14 years old up through 18. Um, it's a really useful study. It's done every year. I think it started in about 1975, and it's been done every year. And so you can track trends. And when you take a look at the younger kids on the list, the eighth graders, and you see little spikes in different areas of what they're either what they're using or what they are thinking is not too dangerous. And certainly right now with marijuana, we see that quite a bit. Use of marijuana continues to increase in youth. Almost all other drugs are decreasing with youth right now. But marijuana continues to rise, and it's matched with the perception of danger associated with marijuana going down to the lowest levels it's ever been measured. So as kids think that something's not too dangerous, then they're going to be more inclined to use it. So a lot of good information comes out of this Monitoring the Future study. When we take a look at their most recent numbers, opiates are really, really low in terms of percentage of use by youth right now. Percentage of use by youth right now. Any use reported in the last year for the three grades combined. Heroin, 0.3% said that they had tried heroin in the last year. Oxycontin, about 2% had tried in the last year, and Vicodin, even less than that, about 1% had tried in the last year. And these numbers are really low. And so there's hope in that both in the Monitoring the Future study itself, and then the NIDA director, Dr. Volkow, have observed that the current lower rates of opiate use by youth, may be hopefully predictive, as they may well take their more cautious behaviors with them into the 20s and 30s. So this might predict that the current epidemic is not going to be picked up by kids as they move into early adulthood and then into full adulthood. That hopefully their reluctance to use these types of drugs will start to decrease. And the current really high-risk groups, which right now, peaks with the young adults. When we look back about 10 years, and some of the other prevalent studies, there was a much higher rate of opiate use by kids about 10 years ago, and so and they're the ones who are really used. We can use that data and say that kids today are going to be using less as they move into young adulthood. So some area of hope. With that being said, in terms of kids are using at really historically low rates, so there's a low incidence of use by youth in terms of the opiates. However, it's not at zero. Some kids are still using, and what does that mean when they move to that level of drug use? So it's a low incidence of very high risk situation. And for those of you working with the younger youth and then moving into the teenage youth, it really speaks to the importance of doing regular screenings to rule out drug and alcohol use, especially if you're working on just the mental health side of things, to do regular screenings to see if there is any level of use. There's a correlation. It's not a huge one, but there is a predictive correlation between mental health needs identified in teenagers and future opiate use. It makes them a little bit more susceptible, it seems. So any kind of mental health work, any kind of substance use work, that we should always be doing regular screenings, even if what's going on. Early cigarette use, early cannabis and alcohol use, and the younger a kid is when they start using any of these substances, it predicts future and heavier drug use and longer periods of use before the person has any sustained abstinence. So when any level of use, and this is including, I'm going to say just, but including just cigarettes, which is actually the deadliest substance on the list that we're talking about today. Cigarette use by itself in early teenagers is predictive of future drug use. So anything that's identified should be matched with some kind of preventive strategy or a treatment strategy. Depending on the level of use, depending on the level of need, matching that with an appropriate level of care. The younger youth who have started using more and more substances, they can be a really good match for Ohio's IHBT program, which is an intensive home-based approach, and it's a full systemic approach. That is, it works with the youth, works with the family, works with the systems around the youth, which is a good match. So we're not gonna dive too deeply into that, but then also thinking about youth, even if they are not using themselves, and the numbers are low, but their parents, their grandparents, their older siblings, certainly these are the age ranges that are using a lot. So youth, young ones, the teenagers, big family systems can really be impacted as use is going on someplace in the family, not necessarily by the youth, him or herself, but someplace in the family. The impact there is lifelong. So, and we're not gonna dive into that one either. But when you think about systemic trauma, developmental trauma, you think about the ACEs studies, things like that. The more intensive help that we can get in systemically, the better off everybody's going to be down the line. How did we get to where we are? We're going to move through these pretty quickly in terms of getting to an epidemic. And I think that there's more familiarity now than there used to be. But in the early 90s, a government panel called for more aggressive pain management before, during, and after surgery. They said we've got the ability to treat pain, we should do it. There was an expectation that if people used medications to treat pain, if they just used it to treat pain, there was a low incidence of addictive potential associated with that. It makes sense from a kind of a logical sense, but as it turns out, if we put more pain medication out there in the community, it's going to go up, matched exponentially in terms of people who are going to be abusing it, and certainly that's what we have seen. There was a push both on the federal level, the medical boards, and then certainly the pharmaceutical companies themselves, all involved in this, and it became so easy to have pain medication. And part of this in '99, pain was added as the fifth vital sign to rate pain, and then that was matched by pharmaceutical treatment. So by 2012, 250 million prescriptions, not individual pills, but prescriptions, were written for painkillers in the U.S. That's almost enough for everybody to have their own bottle of pills, not their own pill, their own bottle of pills. In 2010, Vicodin, which is hydrocodone, but Vicodin was the most prescribed drug in the United States. And at that time, the United States was consuming something like 98% of the entire world supply. It was so prevalent. In terms of potency and effect, Vicodin is pretty low on the list, but it's an easy starting point. And with all of that Vicodin out there, it certainly introduced a lot of people to opiates in general. So when we think about how to classify opiates, we're going to use the CDC classification. I would like to apologize for the confusing blue box in the middle of this screen. I don't know how it got there, and I couldn't remove it. So it's there. But the CDC classifies opiates in 4 categories. There's natural opiate analgesics, and analgesia is the term used for pain relief without loss of consciousness. That's analgesia. Such as morphine, codeine. Also included in this natural then is the semi-synthetics. Those are drugs that come from the natural opiates, but with a little bit of adjustment on the other end. So there's the natural and the semi-synthetics. Methadone is in a class of its own. It's a full synthetic, which is the next classification. But because of the treatment implications of methadone, it's classified by itself. And then there are the synthetic opiate analgesics, opioid analgesics, I should say more properly, other than methadone. And really at the tops of these lists are tramadol and fentanyl. So 1 through 3 are the opioid analgesics, and these are all available by prescription. And then 4th, which is really, this is a semi-synthetic, but again, in a classification by itself, is heroin, which is derived directly from morphine. So the family tree here, the starting point and has been recognized by human beings for thousands of years. It has a really long history, and it's kind of an interesting read in terms of taking a look historically with humans' connection to this. We're not going to go into that today, but I know all of you have tons of extra time. Maybe look it up and do a little bit of reading. But when we go to the source, we talk about the poppy plant itself. Typically not the kind of poppy that you would buy in your local garden center. Those are poppies, and technically speaking, they have a tiny little bit of the raw opiate potential in them. But very specifically, the plant Papaver somniferum is the one that contains the high abundance of the alkaloids involved in this, and that would be raw opium, morphine, codeine, and thebaine. These are all naturally occurring in the plant itself. And then these 3 alkaloids can be used as the starting point and modified into the semi-synthetics. And then there's also the full synthetics, ones that don't actually come from the plant, they're created in a lab. So some of the semi-synthetics, ones that are derived from the natural alkaloids in the poppy plant itself. Heroin, which is just a slight adjustment to morphine. Oxycodone, and that's the primary ingredient in Oxycontin and Percocet. That's derived from thebaine. Oxymorphone, that's the primary substance in Opana. That's derived from morphine. Hydrocodone, that comes from codeine. That would be like Vicodin. And then also buprenorphine, which is derived from thebaine. So those are all semi-synthetics. And then some full synthetics, methadone, and the CDC categorizes it separately just to measure it, but it is a full synthetic. It has been around for a really long time. Fentanyl, and when we think about prescription fentanyl, if you've heard of the Duragesic patch, that's the primary drug in the Duragesic patch. Meperidine, that would be like Demerol, propoxyphene. If you've been in the field for a while, you'd recognize propoxyphene. It's no longer approved. You can't get it anymore. And tramadol, that's all tram. These are all full synthetics. And when we think about fentanyl, you've probably heard about carfentanil. So you start with a synthetic fentanyl, and then an analog of that is carfentanil. It's the most powerfully produced opioid. It's 10,000 times stronger than morphine, 100 times stronger than fentanyl. It's intended only as a large animal tranquilizer. But again, this is something that it can be obtained. It's pretty tough to obtain through any kind of channels in the U.S., but it's one of those things that you can buy online. And you don't just have to go to the mythical dark web. You can find ways to find it online without that level of sophistication. Produced primarily in Asia, and that primarily we think about China. So, um, just pulling from very recent news reports here. This is carfentanil. One is from the Akron area, um, where carfentanil was mixed in, not just with heroin, but some other drugs, and it caused some overdose deaths. Some people were charged with that. Another one just from this month, where a man in Lorraine was indicted in a fatal overdose that involved carfentanil. Um, and the one at the bottom with the two areas blacked out there, it's an email exchange. I know it's kind of hard to read. I tucked it in there to remind myself just to mention. This was a Senate investigation where they were seeing how easy it was to order these types of products online. So this one was, they were trying to buy powdered fentanyl from a Chinese supplier. They did it by email, and it was really easy to do. One of our senators, I think Senator Portman, was involved in this investigation. So they were able to buy fentanyl and carfentanil online. And again, it wasn't a dark web. They found a connection, they emailed them, and they were able to buy it online. So it's not difficult to do. It's getting harder. We're cracking down on it, but just like anything, you can never crack down completely. Kind of growing from that in terms of, as soon as you think you have a handle on what's out there and what to crack down on, this is a couple years old. But I just saw some incidences of it being found in the Illinois area, in the Chicago area in Illinois. This is U47700, is a full synthetic opioid that was previously unrecognized, but some chemist someplace started producing this, and again, it was something that you could buy online, and it has been mixed into a lot of different products, just like fentanyl has. The DEA scheduled it as a scheduled drug, and like a lot of these substances, originally they're not recognized because it never existed before this. So people kind of skirt the law, however briefly, where they'll sell these products because technically they're not legal. If you're familiar with the synthetic marijuana salts, when they first hit the scene, technically they weren't illegal. That's why they were sold as K2, spice, or bath salts, because you couldn't sell them intent for their psychoactive impact. But they were sold with a wink nod, and people knew what they were to be used for. But technically speaking, they weren't illegal. This is pretty recent. This is about a year ago. But pop up again here in the Chicago area. I haven't heard about it in Ohio in a while. This stuff called Gray Death, and I mean that's how it was marketed. It looked dry concrete mix, and it had kind of a mixture of things in it, and they weren't even able to identify all of the stuff that was in it, but they were able to pull out that fentanyl was in it, and the U47700 was in it, and so it was being used, by people kind of like heroin would be used. So here's a picture of the way heroin is frequently packaged. There's the bulk ones. That would be that big blue balloon, and then the clear plastic bags with the large amount in it. And then those little tiny colorful ones, those are little individual balloons, and those are single doses of heroin. And that's the way people will buy that, in those little single doses. And as we talk about the Jalisco network, that's the way that it comes. So I suspect most of you probably haven't seen it, so I wanted to stick that picture in there. That comes from the DEA. I stuck this one in here because just really emphasizing how common how common drug abuse is. And in terms of the opiates, this was from somebody who was complaining about the quality of heroin that he was finding on the street and in his area. I can't imagine posting that. You'd think that you could be tracked down, but but it's just, an example here. There's a little bit of powdered heroin there, and there's some hydrocodone pills and a razor blade there that you can see in terms of the size of things. So heroin itself is diacetylmorphine. It is a semi-synthetic derived from morphine. It was really first created in 1874. It was named heroin because the person is a British chemist who thought that it was going to have heroic possibilities to end morphine addiction. Morphine addiction has been with us for a really long time. And there was a great understanding of the way the biochemistry worked with this. And as it turns out, heroin obviously did not end. Well, maybe it ended morphine addiction, but only because it took it over. Heroin is the most rapidly acting opiate. Our brains are protected by the blood-brain barrier, it operates kind of like a placenta for the brain, where it filters all of the blood from the body before it goes into the brain. And the more rapidly a psychoactive substance is able to pass through the blood-brain barrier and in greater quantities, really the bigger the impact it can have. So morphine crosses the blood-brain barrier pretty easily, but heroin passes the blood-brain barrier like it's not even there. And the interesting thing is once heroin gets into the brain treats it just like morphine. It's just that it gets through the blood-brain barrier faster and in greater concentration. So that's why it has such a much greater impact. Terminology associated with drug and alcohol use, and it's pretty arcane and meaningless. But with heroin, these terms are meaningful. A single bag is about 10 milligrams of heroin, $10 and under, and it's kind of the Sam's Club or Costco approach that the more bulk in which you buy, the lower the price. So you can get a bag, you can get a bundle, which is 10 bags, or you can get a brick, which is 5 bundles, and the more volume that you buy in, the more the price goes down. Most people don't have that because you have to dose with heroin every 4 to 6 hours. And so that's very quickly very expensive. What's available in Ohio right now is predominantly black tar heroin. For a long time, the East Coast had the lighter colored heroin, sometimes called China White, because traditionally it came more from the Middle East. But here in the last 20 years or so, we've had a growing availability coming from the Jalisco region in Mexico. It turns out that the poppies grow really, really well in the mountains on the west coast of Mexico. It's a big part of the economy. So there is what's called the Jalisco Network. Ohio has been ground zero for Columbus especially, but anywhere along the big interstate corridors in Ohio. So Dayton is very heavily impacted by this, and so is Toledo. In that it's kind of it's like an Amway distribution for heroin. It's really non-traditional drug distribution in that very often there's a meeting place. It's not just somebody standing on the street corner. The picture of heroin previously with the little tiny bags, the little tiny colorful bags. A dealer will just hold those in his or her mouth, have a bottle of water close, and if they get pulled over, they just take a drink of water and swallow them and hope that the bags don't rupture in their stomach and that they'll pass through, and then they're okay. But then they're not found with any drugs on them. They typically don't carry weapons. They don't carry large amounts of cash. So they don't really stand out They just look like somebody in the community. So um, it's a popular way for heroin to be distributed in Ohio, and uh, it's pretty well entrenched. Here's some OxyContin pills. These are 40 milligram ones. Um, the opiate in OxyContin is oxycodone. That's a semi-synthetic. There's controlled release tablets in 10, 20, 40, and 80 milligram. They used to be higher, but I think that they stopped producing those. So years ago, 10, 15 years ago, OxyContin was probably the most popularly abused. I don't have numbers on that. I'm basing that on my own experience working in a methadone clinic 20 years ago. As OxyContin became more and more available and distributed, it was the sought after opiate drug because it was very, very reliable. You knew exactly what you were getting every time. They could very easily crush the pills, dissolve them, and inject them. Since that time, though, the manufacturer has made the pills tamper resistant so that they can no longer be crushed and injected. But you have to rely on the time release piece to it. So, if somebody takes them, they can use it to avoid withdrawal, but they're not going to get high off of them in the easy ways that they have in the past. So after OxyContin reformulated theirs, people discovered PANA, which is oxymorphone, which is even stronger than OxyContin. And so it briefly became very popular, but then they made their pills tamper resistant just like OxyContin had. And so, it reduced the abuse of those medications as well. So, fentanyl right now is the growing is the growing full synthetic that is really becoming increasingly problematic. And it's not prescription fentanyl. And there's a picture here. This is a Duragesic patch, which is fentanyl. It's a patch you put on the skin, and it seeps into the system very slowly. You get a constant amount of the drug. And for somebody who needs that level of opiate analgesia, analgesic effect, it's very, very effective, but they're very popular to be abused. But most of the fentanyl now seems to be not diverted prescription fentanyl, but rather it is the illicitly purchased, fentanyl crystal powder coming from overseas, and that's getting mixed into not just heroin to prop up heroin, but like we mentioned before, it's really getting mixed into all street drugs. The picture of the vial there, the person holding up that vial, that is of fentanyl. And if you can see in that, there's just like some powder residue attached to the side of that vial. And that's an effective dose. So that's how powerful fentanyl is. And if that was carfentanil, you just take out 3 grains of that powder attached to the side of that vial, and that would potentially be a lethal dose. So this stuff is extremely potent, and on top of the potency, it's also very, very effective. So this is illicit fentanyl, what it looks like. And pretty recently here, this is coming from the Cincinnati area. And the southwest corner of Ohio has really, really been impacted by fentanyl. And then just the last one in terms of prescription drugs that we're going to cover here is Vicodin. And there's also a medication called Zohydro. So Vicodin is in combination, it's hydrocodone and acetaminophen, and it's an effective pain reliever, that way. But it's difficult to abuse in large quantities. Vicodin itself isn't, it's not nearly as potent as the other drugs that we talked about, but it's a not uncommon entry point for people to start abusing opiates. Zohydro is fairly new, and it's hydrocodone only. It doesn't have the NSAID medication in it, and so there was some concern that Zohydro would be very popular for abuse. I haven't seen any studies on it being abused, and I haven't heard about anybody abusing it. It doesn't mean that it's not. It's just that I haven't heard about it. So when you work with youth, a lot of times, youth are the ones that get a hold of Vicodin, and they will use it in combination with other drugs, especially alcohol, because the adults who are truly addicted to opiates don't chase the Vicodin. Like I said, that's more of an entry level. It's on the lower end side. So and Vicodin was so overprescribed for so long that there's still an easy availability of it, and so youth are the ones who wind up getting a hold of that. So opiates themselves, how do they work? Well, like with any psychoactive substance, they attach to receptors that we have in the brain and in the body, and we have the endogenous opiates, the endorphins in our body, and so opiates work by doing a combination of different things. They reduce our perception of pain, but more importantly, in terms of abuse, they reduce the amount that we care about pain, and they also really tweak the reinforcement pathway, the pleasure center. And in high doses, they really, really hit that center very, very heavily. And when something feels good, any organism is inclined to do that again. And the way opiates really hijack that system, and very, very quickly, 2 weeks of fairly consistent use can lead to addiction with the opiate. And then it gets into, as we talk about, loss of control, and it very much is, in terms of the person's reinforcement pathway. Their thinking has been altered in a way that really hijacks their decision-making process. So with repeated use, then tolerance really starts to have a greater impact, to the point that whenever the body gets used to having a substance in it, it tries to maintain balance. It tries to maintain homeostasis, and so it produces less of whatever that natural chemical in the body is, because it's being put in artificially, and the body also starts making adaptations to push back against whatever the large amount of that drug being put in. And so tolerance builds effect. And so the body starts producing fewer of its own chemicals, and in this case, it's the endorphins, and then also the dopamine-containing systems are really heavily impacted, especially in the reinforcement pathway. And so once the body gets used to having that in there, the person really starts using as much to avoid withdrawal as to avoid to get the euphoric effects of it. So eventually the person starts using on a daily basis, so they're not miserable and sick and depressed, more so than even for the euphoric effects. So when we think about what any kind of drug does to the body, there'll be the drug effect itself on one side, and then on the other side, when the person stops taking it, if they've built up a tolerance, there's going to be a withdrawal. And so typically the withdrawal effect is the opposite of whatever the using effect is, because the body's pushing back, and if the drug's no longer there, then you're going to see the opposite effect. So when we think about opiates, the using effect can be matched with the withdrawal effect, and the using effect is euphoria, and the higher the dose, the greater the euphoria. On the withdrawal side, then, is depression and dysphoria, and it can be very, very significant. And as the person really becomes accustomed to having that drug in there on a regular basis, and as it really impacts that reinforcement pathway, once the drug is taken out, then in withdrawal, that reinforcement pathway is really depleted and just pushes that person relentlessly to put the drug back in the body. There's also an analgesic effect, and certainly, that's the intended use of the medications, is typically for the analgesia, for the pain relief. And then on the other side, even if a person didn't have pain in the first place, just impact the pleasure center in the brain, they impact all the receptors in the body. So the opiates have gotten into the different receptors throughout the body and all of the joints of the body. And then when it's suddenly taken out and there is a withdrawal effect, the person just has aches and pains everywhere, and that leads to irritability. High levels of use, lead to respiratory depression, and this is what's involved eventually with overdose death. And the brain forms tolerances to different things at different levels, and so the euphoric effect may not have a ceiling to its tolerance. That is, it's going to take more and more and more and more of the drug to get to that same euphoric level. But the hindbrain, the primitive part of the brain that is responsible for respiration and heart rate, that does have a ceiling in terms of tolerance themselves at risk, in that to achieve the euphoric effect that they want from the drug, they have to use so much that it puts them at risk of being at a lethal dose then in terms of the respiratory depression. Plus, you can't be certain what you're getting when you just buy a bag of powder. Is it fentanyl? Is it carfentanil? You don't know. And so dosage levels are hard to determine. So respiratory depression with use, hyperventilation on the withdrawal side, relaxation and sleep, which is matched to withdrawal with restlessness, decreased blood pressure, matched with increased flushed skin, and then on the withdrawal side, goosebumps and chills. And as you look down the list on the withdrawal side, it looks like getting the flu, doesn't it? It's just in pain and achy, kind of the short breaths, restless, can't get comfortable, blood pressure's up, you get the chills and goosebumps, diarrhea, runny nose, runny eyes. It feels like the flu, but it's not just the physical symptoms. They're there for sure, but then there is also, your center also has the flu, and that's what really drives a return to use. Signs of opiate use. I don't know that we really need to go through this too much. The slide is there. I think most of us are familiar with this in terms of the way people change, become increasingly isolated. So I'm gonna move past this one pretty quickly to get into some of the other slides that we have, just for time's sake here. Getting to the point where we're going to talk about treatment, and we are not going to talk about specific. This type of treatment is recommended for all people who have an opiate use disorder, because you can't say that about anything in terms of at least behavioral therapy. That we really need to individualize, and so we're going to talk about it in general terms. And the one thing that I do want to include in this is a recognition of medication-assisted treatment. And when we say medication-assisted treatment, or MAT, MAT, typically we think about the medication. Obviously, it's the first word there, but it's not just the medication. So MAT is not just getting a prescription for withdrawal management, but it's in combination with behavioral counseling and medications to really provide a whole patient approach. And then there's a picture of a pocket guide there produced by SAMHSA, it's kind of a nice walkthrough. It's nice to have for clients and families, and really for us as professionals, just to help us walk through and keep things in mind. So you can find that on SAMHSA's website. In terms of medications, the first one we're going to consider is naloxone, or Narcan. This is not under the heading of one of the MAT medications, because this isn't used for withdrawal management or to keep a person from returning to use. But I stuck this one first on the list because, very often this is the one that needs to be administered to counter an overdose, permitting the person to come into treatment at all, for saving their life. So naloxone is very short acting. It has a really strong affinity for the opiate receptors in the body. So even if the body is overwhelmed with, let's say, heroin. And, heroin has attached to all of the receptors in the body, and it's shutting down the respiratory system and cardiac systems. Narcan has a stronger affinity for those receptor sites, and it attaches to those receptor sites. It doesn't turn them on, but it blocks them. And it will get in there, and it kicks all the opiate medication off of those receptor sites, and it gets in there and blocks them. So it essentially it sends the person into instant withdrawal. So they are uncomfortable and not happy, but they are alive. So I imagine many of you saw, it was about 2 weeks ago, I think, it was the Surgeon General of the U.S., Dr. Adams, came out and emphasized the importance of more and more Americans becoming familiar with how to administer naloxone as a public health promotion. So Ohio has had a long tradition through their DAWN network of making naloxone or Narcan available, and that has the availability has increased. It is very accessible for people who are using, or probably more importantly, family and loved ones around people who are using, to get this medication and have it available. So into the medications used in terms of the treatment of the MAT treatment in general, probably the oldest one is methadone. It is an opiate agonist. It does the same thing opiates do. It's been used for decades. It comes in pill, liquid, and wafer forms. It's used for withdrawal mitigation, and it's also used as a pain medication. The nice thing about methadone in terms of withdrawal management is the person just has to take it once a day, as opposed to dosing with something like heroin 3 or 4 or 5 times a day. Take it just once a day. Methadone can only be dispensed through opiate treatment programs, which are certified by SAMHSA, OTPs, so it has to be at a methadone clinic. Patients can eventually earn the right to get take-home doses, meaning that they don't have to come to the clinic every single day. But it's tough to do that. The person has to demonstrate that they are abstinent from all psychoactive medications, and they have to do a certain amount of counseling and psychotherapy before they can earn that privilege. But otherwise, they have to come to the clinic every day. But methadone, once an effective dose is found, it stops having the euphoric effect that you get from abusing the opiate medications, but it completely stops withdrawal at an effective dose, and it blocks the euphoric effect, so it decreases the likelihood that the person is going to be using other opiate medications. So there's some pros and cons about methadone that people talk about, but it has been an effective treatment for a long time. Another one is naltrexone. This is a full opioid antagonist. That is, it does the opposite of an opiate. So it blocks the receptor sites. It's similar to naloxone, but naltrexone doesn't act as quickly as naloxone or Narcan does, the overdose drug. So it takes longer for it to have an effect, but then it lasts much longer in the system. I think most famously for treatment, or most commonly for treatment, there's the injectable formulation, Vivitrol, an intramuscular injection. The person gets it once per month. The nice thing about now, any kind of special programming or licensing, if a doctor is licensed to prescribe, then they can prescribe naltrexone. It does require that the person has completed a full detox before they start this, though. So it can be a little bit harder to start that because they will have to be completely detoxed from blocks the effects of any future use, which provides an extra layer of protection than when the person is working to stay abstinent. And then the third one on our list is buprenorphine. This one is, I think, confusingly, a partial agonist. not an antagonist, not a full agonist, but a partial agonist. So it produces opiate effects, but at much weaker levels, and it has this healing to it in that at higher doses, it stops having any impact beyond a certain point. It can be diverted and misused, but because of the healing effect, it's not misused for its euphoric effect ability. It's typically diverted and misused as a withdrawal maintenance drug. So the abuse for really damaging diversion is much, much lower with buprenorphine. It can be prescribed by qualified physicians. They have to do an extra bit of training, but it doesn't have to go through one of the OTPs. Products with buprenorphine in it, I think the most commonly recognized is Suboxone. And it's interesting the way Suboxone works to really decrease the likelihood of it being diverted. It dissolves in the mouth, and the film also has naloxone or Narcan in it. So as long as the person uses it as it's intended, they put it in their mouth and it dissolves. The buprenorphine is absorbed through the tongue and cheek pretty effectively, but Narcan is not. So as long as it's put in the mouth and dissolved, then it works. But if the person tries to divert and dissolve it and then inject it, then the Narcan becomes more active and it blocks the effects of anything else. So it's very discouraging to use that way. So there's also a couple other products that do the same thing. A pretty new one is Sublocade. This is a recently approved monthly injection of buprenorphine, similar to the Vivitrol in terms of monthly injection. And then there's Probufene as a 6-month subdermal implant. Just goes right under the skin, and it provides a constant availability of the drug. So coming from NIDA, and this has been echoed by SAMHSA, that MAT is underutilized. And the thinking about that is that the combination of psychotherapy with medication management the medication part has a big stigma, even among treatment providers themselves, in that the person then is just trading addictions. And then even when medications are used, there's an insufficient dosing level and length of treatment. So NIDA and SAMHSA are both trying to they're both trying to combat that, because we know from studies that higher doses and longer lengths of treatment with medications increase a person's likelihood of staying abstinent from illicit opiates and remaining involved in counseling. So, and both of those are really important, obviously. So the target of medication-assisted treatment is to obviously decrease overdose death, to decrease infectious disease spread, to increase treatment retention, because if a person's not in treatment, change is far less likely, and also to decrease criminal activity. So, I mean, it's a pretty wide-ranging approach with this. Coming from recently published tip manual, if you're familiar with those, the treatment improvement protocols by SAMHSA, that medication increases treatment retention, decreases illicit use, and stabilization with medication assistance is better when a long view and course is used. That is, short-term withdrawal management is not very effective at preventing a return to use. But when a prescriber and a patient work together to find the appropriate dosage level and stay committed to staying on that medication for, I think what I saw in the tip manual was at least 12 months, which is a lot longer than understandably that people would hope for, when I get this behind me kind of thing. But taking the longer view, it really increases treatment retention and decreases a return to illicit use. So in terms of behavioral and counseling approaches, coming from that TIP 63 manual, dedicated counseling can help clients address the challenges of extended recovery. And they point out, just as we said a few minutes ago, no single treatment is effective for everybody. There is not one match that works for everybody. Effective treatment attends to multiple needs of the individual, not just his or her drug use. And that's really important. It's not going to be just medications, and it's not going to be just drug and alcohol counseling, or in this case, opiates drug counseling, because that's not the entirety of the person. And we know from a lot of research that when somebody has an identified substance use disorder, there's a very high likelihood that there's going to be a co-occurring mental health disorder happening at the same time, at over 70% predicted level. So if we just try to tackle one side with the person, that is, we're just going to tackle drug and alcohol use or drug use, you're ignoring the gestalt of the person. And if you just tackle one side or just one component of that individual, without helping that person address the other factors that are occurring, that's going to really decrease the likelihood of successful change. So substance use disorder is rarely occurring in a vacuum. Typically, we're going to expect co-occurring mental health. And a lot of times when people have been using opiates for a long time, there's going to be comorbid physical conditions, family and system issues, legal and community issues. This is the circle slide there, the circle piece. This is something we use in some of our home-based programs, working intensively with youth and families. In terms of, you take a look at the identified client there in the middle, and here it says youth because that's what we work with typically, and we think about safety issues around the individual, but then all the other aspects involved in a person's life that have to be considered as part of their life. It's a full biopsychosocial approach. So behaviorally, working with adolescents or adults in terms of sustained recovery from opiates, mixing some motivational interviewing, some motivationally enhancing conversations. A lot of times when they get to the point that we're going to be doing in conjunction with some medication-assisted treatment, the person is maybe a little bit more ready to talk about change, so we can start infusing more other cognitive behavioral approaches. Case management addition is very, very helpful a lot of times because of these different domains in the person's life that have suffered with their ongoing use. Family and relational inclusion. It's very important to include the family as much as we possibly can. And then considerations about readiness to change across multiple dimensions. The person may be coming in and very ready to talk about wanting to change their opiate use, but how ready are they to address the family anger and the family system and the depressive symptoms in their life, and how ready are they to discuss financial matters and physical health matters. So a person can come into treatment with many, many different layers of motivation to change. It's not a single motivation to change. So, we really promote an integrated treatment planning approach, from integrated treatment or from integrated screening, assessments, integrated treatment planning, and as much as we can integrate this to a single client is going to be. So resources in some resources that maybe that you can use, and I just tacked in a couple here. I really like this one. This is Preventing an Opiate Overdose. This is for clients, for families, and really I think for treatment professionals as well. This one's produced by the CDC. It can be accessed. The link is there at the bottom. And here's the TIP 63 manual from SAMHSA. And then I also included recognition of TIP 42, which is substance abuse treatment for people with co-occurring disorders. All of the TIP manuals are they're written so that they're really easy to understand. They're very accessible. So Um, and this is our final slide. Congratulations if you've made it this far. Thanks for sticking with us. Ohio has produced a lot of really good information, and there's the action guide to address opiate abuse. This is produced here in Ohio. The Ohio Mental Health and Addiction Service website has a lot of information and linkages to opiate identification, the prevention programs that are out there, and helping find and match some treatment. NIDA has a lot of good resources. SAMHSA has a lot of good resources, and the CDC has a lot of good resources. So that's where we're going to wrap up today. I hope that this gave a decent overview. Like I said, there weren't any great specifics. There was nothing revelatory coming out of this, but hopefully increased awareness of really how common things are in terms of opiate abuse. Maybe a little bit of hope in there, and then some areas where possible that you can link to for further assistance. So thank you very much, and keep doing some good work.